1 second. Let me check on the live. Wait. Open different page. Something. Open different page.
Okay, I'm opening. Will you able to see my folders?
Yeah, I could.
So it means it's working fine, no? Now I'm opening Excel.
Yes, Nima. Now it is working fine. Okay,
Okay.
open the image of the webinar and keep it on your screen. That's it.
Okay. Now we are live now.
Yeah, you are live. Open the image of the webinar and keep it there. That's it.
Now after that, nothing I have to do.
Nothing.
Okay. Okay. Fine. Hello,
Okay,
sir.
Nimaji. Yeah,
Yeah,
I will
please.
drop off. Yeah, I'll drop
Yeah.
off. Yeah.
I have just one query. Now the faculty is joining one by one. So as we are live, after their joining, can we go live?
No, don't do that. If you click on
Okay.
end stream, everything will go. Let the faculty join. That's not a problem.
Okay.
Okay, so you just have the webinar on your screen. If people are joining, you admit them. That is
Yeah,
fine.
that I
Okay,
do.
you close all your other tabs. Okay.
Okay, fine. Yeah.
Yeah.
Hi, Nima.
Hello, sir.
I think we need somebody from the, infection group to coordinate this because by 7:15, I think the faculty has to join.
Yes, sir.
If they join by 7:30, then everything gets delayed.
Yes, sir.
I think we'll need somebody from that team to coordinate.
We are live now, sir.
Okay, I think, yeah, that's okay. Why we should be live? I think live can become only at
7:30, I told that Prem. Should I
ah,
stop line?
yeah, live has to be only at 7:30.
Yeah, when everybody join us, sir.
Yes, yes.
Let me do it.
Yeah, people, everybody has to join through the Zoom link or they can join in the YouTube channel.
They can join through that link shared. Another link, sir. Not this one.
Okay. This is only for the
Faculty.
faculty. Okay, right. Thanks.
Sir, now as per Prem, now we can't stop. Because if I end the stream,
No, there is a way where it will go live at a particular time. Next time we should do.
Yeah, next time we will do it because this is first time, na sir?
Yeah, it's okay.
Yeah.
We'll come, everybody will join, and we'll go live with the
Yeah.
countdown at 7:30.
That same issue I raised with the Prem. He said now it's let it be. For next time we will do because it's not look good, na sir. Your faculty is
Yeah,
talking.
now it becomes too difficult.
Yes,
And
sir.
also, it doesn't look good when you talk, everybody is listening.
Actually, this is first time for me, na sir. Now,
Okay.
yeah.
I understand. We have to allot somebody in charge of it.
Yes.
Okay, thank you.
Good evening, sir.
Nima, good evening.
Good evening, sir.
How
Good
caise-
evening. We all here, ready.
And we are live now, sir.
Okay, Bharat bhai, hi.
Hi.
President sir, hello. Seven minutes more, huh?
Yeah.
Yes, sir.
Okay.
Sir, Ajay sir is here.
It's okay. We'll join back in another 5 minutes. Hi, Tushar.
Tushar, Ajay, hi.
Hi. Tushar is still in Thai. You are in the clinic.
No, sir. Just finished the clinic. I just finished
He
it.
just finished an osteotomy.
Abhay sir's Zoom room is same as it is I seen from COVID room. Same spots. Same
Same.
at the same spots.
And it's a genuine background.
Bharat?
He is muted, sir.
Okay.
Good evening.
Bharat, you can do the introduction. I think we are right on time.
Yeah. Good evening, Ajay.
Good evening, Bharat. Yes,
Good
sir,
evening.
and boss over there. I think probably sir should do.
Morning, sir.
Hello, sir.
Sir, you are muted. Good evening, sir.
I'm good. Hi. Now you can hear me?
Yes,
Yes,
sir.
sir. Yes, boss. Good evening, sir. Yeah, good evening. So always I see a guitar and a piano behind
Yeah,
Abhay.
but you never hear me play it. Where Amita sitting out, she'll bamboo me if I play it.
Hi, Bharat.
Good evening,
Bharat.
No, sir.
Yeah. Pankaj is also in.
Sure, Ajay. Good evening.
Yeah. So, okay. So what is this? It will go through Ortho TV or YouTube, huh?
Sir, YouTube. We are live now, actually.
Oh, I see. Okay. So I'm okay.
There will be a 1.5-second delay.
That's okay. No problem.
Right now, Nima?
Right now,
Yes,
there are
yeah.
49 viewers.
That's okay, Nima.
That's okay. I mean, people can see later also, we have said, no?
Yes.
Wonderful. Very
I
good.
don't think you are live now.
Sir, we are
Yeah,
live.
live.
I'm checking in another phone.
சரிப்பா நீ போலாம்பா போயிடலாம்
Are we live? I don't think so.
Yeah, we are live.
Yes, sir, we are live, sir.
So then we can
You
start.
can start, sir.
Yeah. I have to go or you're the.
You can start with you, then hand over to me and Bharat.
Okay. Good evening. It's a great pleasure to welcome all of you for this ASSI webinar. And I would like to congratulate Basu, our past president, for initiating these programs. And he was instrumental in starting these focus groups. And these focus groups are having a webinar that will be covering all the important topics. And today we start off with something that we see day in and day out, spinal tuberculosis. And we have very eminent speakers of Abhay, Tushar, Pankaj, Varun, Ayon, and Sri Ramalingam. And I'm also grateful to Ajay and Bharat for moderating this session. And I'll hand it over to Bharat and Ajay.
We welcome you all in this ASSI webinar. I think that's a great initiative, and we all know that one of the most common topic, and the government of India has decided to combat this tuberculosis, hopefully by December 2026, make it to zero. So, this seems to be the one of the most active step from the ASSI. And without delay, let us invite our first speaker, Dr. Abhay Nene, to give his talk on the current concept in the chemotherapy for spinal tuberculosis. So over to you, Abhay.
Thank you so much, Bharat Bhai. So I think the first talk is the only talk on non-surgical treatment. So I'm going to slide in a few things about which are slightly outside the rules of chemotherapy. Everything about conservative treatment. So to begin with, this is a bunch of cases that came to us which were on empirical AKT. And if you notice, all the diagnoses were everything other than TB. So here's another set of cases that came to us in our clinic, real time, which were diagnosed as non-TB when all of them were actually TB. So it was an atypical presentation of TB. So the rule number one of non-surgical treatment is that avoid making a pure radiological diagnosis of spinal TB because there are lots of mimics. It's a great mimic, we all know, and try to get a biopsy in all cases. Now, let's go through some clinical scenarios that you may find in real life. So the first is that you have a patient who has a biopsy and culture proven primary TB like this. So you've got this case, you put in a needle and you've got everything going for TB. The question is, what kind of AKT regimen would you use? And in the current scenario, would you use streptomycins? Would you use ofloxacins? I mean, all the floxacins, and would you think about compliance? Now here's the here's the detailing that a 12-month regimen of EHRZ is enough, and there's no added benefit of streptomycin. I say this because in the orthopedic circles, there's a understanding that streptomycin penetrates bone better, which has been proven to be not true. Now, also remember to give all your patients vitamin D supplements because vitamin D related immunity is one of the known causes for reactivation of spinal TB. Ensure correct doses. This is something that we as surgeons don't do. Make sure that the dosage is correct, and if you're not sure, consult somebody. Explain the method of rifampicin intake. It only works if it's taken on an empty stomach in the morning. Explain the common side effects because many of your patients will go off AKT looking at the side effects, and give them a sense of the duration of treatment so compliance is comfortable. The second rule is that do not add a single drug to a failing regimen. So at any point, if you feel that you're not sure that this patient is going to respond to your primary regimen for whatever reason, adding one, ciprofloxacin is not going to make a difference. It's going to actually is like adding a lame horse to a chariot that's failing. So the rules are very different when you want to add additional drugs. Now, what's the scenario when you have a person who's improving clinically and radiologically there's a lag, and that's a common scenario? So how do you monitor response to primary chemotherapy? So here are the three parameters that you would want to go through. The first is clinical improvement. So priority number one is that the patient is getting better clinically: weight gain, better appetite, reduced pain, improved mobility, better spinal signs. There's a high chance that the patient is getting better no matter what the radiology shows. The next would be radiological improvement, MRI and X-ray, and the third would be lab markers. So we normally would advise recheck in lab markers every 3 months, and an MRI we normally would do at 3 months and at stoppage of treatment. We often do it every 3 months, but that's controversial. The next rule is so the rule here is that you want to use all the criteria available at your disposal, and remember that clinical criteria significantly outweigh radiological and laboratory criteria when you want to consider whether the patient is healing or not. Now, here's another scenario where a patient after 12 months of AKT, a primary culture proven TB, is now showing radiological lag. Like the patient is clinically completely okay, but on radiology, there is still soft tissue seen there. Would you continue chemotherapy in such a situation? The duration of chemotherapy in spinal TB. And we now have good enough data. So the study that we published some years ago was suggested that it was a randomized prospective single-blinded study where we had 50 patients in a 6-month AKT arm and 50 patients in a 12-month AKT arm, and all were studied till 2 years after stoppage of AKT to look for recurrence. And the endpoint of treatment was no recurrence 2 years after stopping AKT. All these were culture proven primary TBs, and we could conclude that 6 month chemotherapy for a culture proven primary TB was as good as 12-month chemotherapy. So at least what we could fully conclude was that you don't need to give AKT for a culture proven primary spinal TB for longer than 12 months. And that debate is now over. And all the experts that are seen in this, on this image would agree with that. And we've learned this from their teachings also. Now, here's another clinical scenario where, despite AKT, the patient is worsening, and you go back and you find that the culture is non-representative. So you don't have good samples. Here, you want to think of drug resistance, because drug resistance is much more common than anticipated. And if you look at the statistics, it turns out to be about 1,000 MDR spine TB cases every year in India. So it won't be surprising if your case is that, especially if it's a child who are exposed to primary drug resistant infections. They are likely to get drug resistance. There's almost a 10% incidence of MDR TB spine in children in our Vadia hospital series. And there's a set pattern of patients, like defaulters, patients who've had inadequate doses, history of irregular drug intake, known contact with MDR cases. These are the people who you should suspect MDR and then go ahead and do their MDR checks. There's a big list of drugs that are every few days there's a new drug that comes up for second line AKT, and the complications of these drugs are significantly higher, and hence you want to know that the standard second line AKT regimen has now been given by the WHO, and these are the five groups of drugs that are used. You can find this anywhere on the internet. But we must involve a chest physician who's well versed with the treatment of the principle of handling MDR-TB, and not just any other chest physician, to take care of your MDR patients, because there's too much going on in that space. And there's new medicines going on, coming in at every few months. You got to know what remains where. And then finally, what is new in the medical treatment of spinal TB? So let's look at some interesting data. The first is about FNAC. So we would do FNAC of TB lesions, but now we know that a CT guided 11 gauge needle biopsy with multiple samples has a much better chance of success than an FNAC. So this could be surgeon driven or it could be radiology driven. Now, when we do take this biopsy, remember, we were brought up thinking that pus is non-representative, but now there's enough data to show that pus is equally representative as granulation tissue. So don't miss out on taking pus samples also. And multiple samples, up to 3 samples, are recommended for to get the most likely positive sample in your, to get a most likely chance of getting a positive sample. Send the sample in a sterile container in formalin and send a smear to a reliable lab. Once again, every lab is not a reliable lab. There's a lot of contamination issues. The gold standard for TB culture remains TB MGIT, and this is the only test currently available to detect live bacteria. And we'll talk about it a little more. The biopsy sample that you get should be sent for AFB culture, which is MGIT. It should also be sent for smear. It should be sent for histopath. The biopsy sample should be sent for Gene Expert Ultra. Now, if MTB is detected on Gene Expert Ultra and the patient has not been on treatment, you take this sample and proceed to the line probe assay for first and second line drugs. If the patient is already on treatment, you send the patient for pyrosequencing. So this is the take-home message on what you do with the sample when you get it from the biopsy, from the biopsy tissue. The newer tests that are available for a better or a faster diagnosis of spinal TB, let's quickly go through them. So the Gene Expert is the way to go because it gives a very quick diagnosis within a few hours, and you can have a positive Gene Expert even in a negative sample. However, there are some things that you should know about the Gene Expert, that there are false positive rifampicin sensitivity results in certain cases and false negative rifampicin sensitivity results. So you can't hang your hat completely on Gene Expert. So especially when your cycle threshold is low. So when MTB, like you see in this report that I put up, MTB detected very low. The RIF resistance, if it's detected, there's a likelihood of this being a false positive resistance. So in a very low threshold sample, you can't rely on the resistance pattern. Negative Gene Expert does not rule out TB. Positive may not indicate viable organisms, especially if there's a past history of TB in your patient. And if AFB smears positive but Gene Expert is not detected, think about atypical mycobacteria. There's Gene Expert Ultra, which is now fine-tuned Gene Expert, and it's 8 times more sensitive. And even in very low cycle threshold, you can rely on it. So the Gene Expert Ultra is the way to go. The LPA is a much better test, but it takes longer. It takes 48 hours. And what extra information the LPA gives you is it tells you about high dose INH, which means that there are certain mutations that where even if there's INH resistance, because 16% of Indians are INH resistant, so even these folks could do well with high dose INH, and that's important because INH is one of the best drugs available for TB. Why is LPA not popular? Because theoretically you need a smear positive sample and most spinal TBs are smear negative. However, there's a version 2 of the LPA available, which now is positive in smear negative samples also. And then finally, pyro sequencing of the MDR and XDR TB is the current way to go because it gives you a full menu about the entire drug list and it tells you which drug is sensitive and which is not. And the last bit on PET scan, because there's a lot of buzz about the PET scan in spinal TB. And here's a case to exemplify why I don't particularly believe in this PET scan. So here's a case which was, which is supposed to be a spinal metastasis, positive on PET scan. PET scan reported this as a metastasis when indeed it turned out to be spinal tuberculosis. So what we conclude is that the PET scan is sensitive but not specific for TB. It tells you about inflammation, doesn't necessarily tell you about infection. So finally, the uncomfortable truth is that you're going to hear a lot about surgical techniques, but they are all going to fail if your drug technique and giving your AKT and your monitoring techniques are not okay. Because our management of spinal TB has come in full circle from non-operative treatment to systematic non-operative treatment back again. I'll end my game there saying that there's a huge scope of non-surgical treatment. Exercise that scope before you think of doing fancy surgery. Thank you.
Thank you, Abhay, for that excellent talk. And we know that, the tuberculosis is a medical disease, and we really need to know and we really need to execute each and every step that you have mentioned. And recently we had one of the discussion on the biopsy, and we have started ETOing all the sample, tubes in order not to have the contamination as well. So that is something which we have started doing. So thank you, Abhay, again. Now I request our beloved and most respected SR sir, Dr. Rajshekharan sir, to give his talk.
Thank you, Bharat. Are my slides synced?
Yes, sir.
Okay, thank you. So Abhay actually said that we are coming back to policy where we only operate on required cases and not on all spinal tuberculosis cases. And one of the real indications for surgery nowadays is instability and neurological deficit. If you look at the actual incidence of neurological deficit, we can find that it's how we look at. In developed countries where people come earlier, it's 10 to 20%. But if you're looking at even small changes in your jerks and reflexes as a neurological deficit, then it can be higher than 60%. So that's a very large number. And we also know the reason why we get a neurological deficit in pyogenic and TB are completely different. So here is a pyogenic. You can see that the epidural abscess and compression is very less, but the patient has a large changes in the cord and they come with a complete deficit. But if you look at all the results of people who have examined why there is a neurological deficit, they have found that mechanical instability and neoplasia in that there is in trauma and mechanical instability is always told. But if you are talking about infection, the things that are told is 50% of canal encroachment, cord edema, kyphosis greater than 30 degrees, and cord compression as predictors. Now, there is a lot of other papers which have come out on predicting neurological deficit, and they also have only focused on epidural granulation tissue, caseous material abscess and sequestra, which are pressing on the cord, and also compression and stretching due to deformity. You will find that instability is not discussed as a major issue over here. But this is a frequent syndrome where we see that you can see there is a very large compression. You can see it's in a thoracic spine, a very high risk area, a very severe compression, but still there was no neurological deficit and the patient recovers well with chemotherapy. On the other hand, this is another example where you can see there is a lot of compression in the cervical spine and still no neurological deficit, and the patient has recovered. On the other hand, we also know that patients come with neurological deficit, but there is no severe compression. So this actually makes you to wonder whether that instability can really be the factor which moves the coin from neurological deficit to no neurological deficit. And why? Because even if you have a mild transplantation, it can be the worst compromiser for the canal diameter. I'll dwell on it little in detail later. And instability gives dynamic and repeated trauma to the cord, can cause both stretching and compression simultaneously. It causes increased kinking of the cord over the gibbous and can stretch the neural elements quite a lot. So if you look here, there is a small translation, which may not be think that it is not so important. And usually we look at the sagittal lateral view to look at what is the severity of deformity. But even if you have a kyphosis, you will find that many times the cord is not so severely compressed. But when you have even the minimal translation, you can see that if you superimpose the two canal diameters of the superior and the inferior vertebra, you will find that this is the only space available for the cord now. So if you diagrammatically chart what happens to the canal diameter when there is a translation, you will find that the decrease in the canal diameter is non-linear and the overlap drops rapidly even for very small shifts. So even for very small instabilities, you will find that with minimal compression, instability can cause cord injury, and dynamic injuries called cord kinking, stretching injury, axonal loss, and repetitive micro-motion trauma can be the problem. Now, why instability happens in speed TB? We know that it is a disease of the anterior column. And once there is a sufficient decrease and there is a collapse, the facet joints decrease. And then that will lead to the death of the column. And this is almost what you see over here. There is a anterior column deficit over here, and there is a posterior column give way. And you can see that this vertebral body has completely translated over here. Now, this is almost similar to what happened in the Twin Towers when two columns or two vertebrae go away, and then the whole system comes crashing. And that is what happens in buckling collapse. I'm just putting the slides because instability should not be thought about to be only in acute cases, but even in chronic cases when there is an instability, it gradually leads to the kyphosis and the apex becomes sharper. The cord stretch increases. So there is a sick cord syndrome, and slowly this progresses and deficit can then progress slowly or sometimes even suddenly. So you need to be careful and cognizant of the instability in acute and chronic cases. Now, what happens is the static compression is seen on MRI, but the dynamic instability is often not seen on a supine MRI. And so we forget the fact that the neurological deficit is usually due to compression, but more of an instability, and we should be aware of it. So the neurological deficit in TB is actually due to a dual mechanism, and we should be careful about it. So why is instability often missed? Because MRI is done supine and motion gets eliminated, and the destruction is very gradual. So our focus is on abscess, cord signal, and kyphotic angle. So this is a patient who is typically 36 years male on treatment for TB, sudden onset of neurology. But here you can see that when we look at it, we are focusing on what is the amount of destruction and how much of the canal compromise is there. There is a large epidural abscess over here. But even when you look at the lateral view or the sagittal, we don't recognize that what is actually happening is a major instability over here. So we need an objective assessment for instability every time you see over here. Now there are many scores. Now this is the TSIS course, which was proposed by many of our members of the ASSI. This looked at age, location, pain, adjusted kyphotic deformity, vertebral body loss, posterior element involvement, multifocal contiguous disease, and also paraspinal abscess. So we had a little bit of a problem, and then what we thought is that there are some conceptual issues with this, because this score mixes disease severity with true mechanical instability, which may risk misclassification, and including pain is too subjective, because heavy scoring for pain may inflate instability score. Further, we also thought that biomechanical gaps were there, which was they totally ignored spine at risk signs, deformity angular ratio, and clear measures of translation and angulation were not mentioned. So we went on to do another instability score. This was done in many phases. In phase 1, 10 senior spine surgeons created an initial questionnaire. And in phase 2, it went on to a global survey where 68 spine surgeons from 12 countries looked at it. They validated with 60 real spinal tuberculosis cases. And in phase 4, we did a statistical validation of sensitivity, specificity, repeatability, and inter-observer reliability. So in the end, what was translated was that we had 5 factors: age, less than 15 years, junctional involvement of only cervicothoracic and thoracolumbar and not lumbosacral. Sagittal deformity was by DAR, and vertebral body loss and segmental ratio of greater than 0.5 and spine at risk signs were considered to be the most important. And we know how the deformity angular ratio is calculated, and the vertebral body loss is calculated, and the spine at risk signs, which we have discussed very often. So in the end, these 5 were given weighted scores. The total possible was 9, and a score of 3 was considered to be highly unstable. Now, a good example is you can see here that there is a very severe compression of the cord. But however, if you go through the actual score, you will find that this is not unstable. And so this patient was treated conservatively. Another patient who presented with severe neurological deficit, you can find that the epidural abscess is present. But then if you look at all the instability score, as we had described before, it came up to 7, and this is an unstable spine. And so chemotherapy alone is definitely not required here. There is no place for a middle path regime, and these patients must be operated. Again, another example where on the initial looking, it doesn't look to be unstable, but you apply the score, it comes as 7, unstable spine. And again, these patients should be stabilized, otherwise the recovery is very low. So we also did a study where we wanted to prove that instability mattered more than all the other compressive elements. And this was done by our ASSI spine fellow, Dr. Hari Krishna. The hypothesis was that instability independently causes neurological deficit. And we did a retrospective cohort where with our IRB approval, we included microbiologically and histopathologically proven TB with complete clinical and radiological data. And from the PACS, all the canal encroachment area, vertebral body loss, kyphosis angle, DAR, spinal risk signs, instability category, cord signal, epidural compression, all these were completely done. And then this was the way the epidural compression was validated. And in the end, out of the 122 patients who had completed data, we found that the neurological deficit was present in 32.8 and surgery was performed. And we looked at all the other potential parameters. And what came out was that there were 4 patterns. We could divide all of them into 4 groups. Patients who were stable and no compression, the incidence of neurological deficit was only 1%. Patients who had stable spine, but there was a compression, the probability was only 27% of neurological deficit. If the patients had unstable spine, as defined by the score, but there was no compression, but still there was a 50% incidence of neurological deficit. And if there is unstable and compression, then the probability becomes 63%. So you can see that instability is more important than compression, and when they are combined together, then you have the highest risk of neurological deficit. So it just shows that whenever you see a patient with spinal tuberculosis, that we not only look at how much there is a cord compression and what is the site and how much there is a canal compression. It's also important that we look at what is the amount of instability over there, because instability can be an independent factor that gives rise to neurological deficit. And unstable spines, even though they don't have a neurological deficit, should be stabilized earlier because they can precipitate with a slow or a sudden onset of neurological deficit. Thank you very much for this opportunity. Thank you.
Thank you, sir, for elaborating the role of instability. Any questions for him?
We are taking questions at the end. Ajay.
Okay. We'll invite the next speaker, Tushar, who's going to speak on something which we knew as postgraduates, and especially applicable to other parts of tuberculosis in the appendicular skeleton. But Tushar is going to enlighten us our understanding on dry and wet TB in axial tuberculosis. Over to you, Tushar.
Sir, you
You're
are
muted.
muted.
Is my slide visible now?
Now we can see you, Tushar.
Okay.
Yes, sir, it's visible, sir.
Fine.
So thank you, ASSI study group and Ajay sir for giving this opportunity. So we all just learned by the excellent lecture by Raja sir regarding the instability as an independent risk factor for a spinal tuberculosis. And my focus will be here to differentiate what is a dry and wet spinal tuberculosis that we talked about. So we all know that the neurological complication is a part of spinal tuberculosis, which can occur up to 10 to 30%. But normally a large destruction, abscess formation, instability, deformity will cause, which is known as a weight form, will cause a tuberculosis, and ultimately it can respond very well to the AKT and surgery, and you get a good recovery and ambulation. Whereas sometimes it is a minimal destruction, minimal abscess formation, no deformity, no instability, so-called dry form, but the patient, in spite of given a AKT and surgery, there's a significant residual disability and the patient may remain non-ambulatory. So there's a significant variability in terms of outcome, the severity, and the expected recovery. Normally, we understand that whenever the disease has a more destruction, more abscess formation, more lesions, the poor is the recovery. But in this form, dry and wet form, it is inversely proportional. So for a dry form, which has a less destruction, still the disability can be very severe. For example, this is a 50-year-old female who has a D10, D11 spondylodiscitis. She was on a AKT for 8 months, and commonly this dry form, because the MRI appears so benign that most of these patients are put on a AKT, but she started getting a deficit since 1 month. And similar age group patient, another level, but you can see a D11, D12 with AKT 1 month and duration of deficit is since 15 days. So when we do actual MRI, you can see that the type A person, where there is a dry form, the cord is relatively well preserved, whereas in a type B, where there's a significant abscess formation, the compression of the spinal cord, effacement of the spinal cord, there's a compression happening. And we always wonder how is the recovery or the neurological outcome in these patients. Both patients were kind of ASSI, though it's not a classical hallmark. We had used LEMS score also. And what is the recovery? So what was seen is that in spite of offering AKT and surgical treatment to both of these patients, the type A patient, the one with a dry form, had an unsatisfactory outcome, and he was ambulatory with support at the end of 12 months, whereas the patient 1B, who had a significant weight form of destruction, was ambulatory within a period of 1 month. Such is the difference in the recovery. Another patient, again a spondylodiscitis in a D11, D12 lesion, you can see a minimal destruction, but there's the granulation tissue relatively preserved posterior epidural space, whereas in this patient there's a large epidural abscess, significant destruction, instability. When we do actual MRI, you can see a granulation tissue in the canal, whereas there's a large epidural abscess which is compressing on the spinal cord. And these patients had a severe deficit at the time of presentation presentation, but when we offered surgery, the patient A, the dry form, remained non-ambulatory even at the end of 4 years, whereas the patient with the wet form became ambulatory by the end of 3 months. So this is what is the basic talk about. So we wanted to discern what is the wet form. So wet form is the one which has a large abscess formation where there's a significant prevertebral and paravertebral abscess with the epidural component which can be seen on an MRI. These are classically a subligamentous abscesses which you see, which are usually underneath the ALL. They displace the aorta as well, and there could be an epidural component anterior or posterior. And when we operate this patient, usually what we see is that once we stabilize the patient, they are usually the one with a large abscess formation, discharge which comes out intraoperatively. And these patients usually go on responding very well. So provided you give a good stability, you do a good fixation, these patients recover very well following a surgery. Sometime when you do abscess, you can also see a significant amount of cassation. This wet form can be with deformity and significant cassation formation in the front side. So that is also something which we commonly see. Whereas the dry form, which is the different variety, which is less common variety, which has a significant neurological deterioration, which can be seen in these patients. What we see inside is the abscess formation. So usually it's a granulation tissue which is compressed on a spinal cord, and this granulation is the one which encircles the spinal cord and can cause a deficit. So this can be seen as an adhesive band which constricts the cord, and if you release it properly, the patient may get a good recovery if it is done in a timely manner. But a lot of times you can see a significant granulation tissue in this kind of a patients and not much of abscess formation. So another case like a dry cox, where you can see that the MRI shows a minimal destruction in a spondylodiscitis. There's a significant cord signal changes at the same level. When you do a contrast MRI, what you can see is an enhancement around the vertebral body. The spinal cord is slightly enlarged. So another typical feature of this dry form of tuberculosis which we observed is the relatively preservation of the spinal cord diameter. But other thing is that you can see a significant signal changes in the substance of the spinal cord, which itself can indicate a myelitis. So when these patients, in spite of you do a thorough decompression, because they present with a significant deficit, and you do adequate stabilization, this is a MRI at the end of 1 year, you can see the cord has been completely decompressed, but you can still see a significant changes in the substance of the cord, and patients do still get a unsatisfactory recovery in spite of doing a complete, and they remain with a lot of spasticity. So that is how the dry forms behave at the end of a treatment. So this was what we decided to study, because, and this we published recently in a spine journal, whether the dry form of tuberculosis differ from the weight with respect to the recovery and the prognosis. And this is what I will just talk about recently, our findings, what we found. So it was a retrospective analytical study which was conducted between the 16 to 23. We had almost 18 patients of dry spinal tuberculosis and 22 patients of wet spinal tuberculosis. So it is very difficult to define the dry tuberculosis, because literature mentions the dry tuberculosis is a vague phenomenon. There is no clear, settled definition of the dry tuberculosis. So after doing a thorough literature, we found that the granulation tissue was the most consistent finding on the MRI, and we decided to another minor criteria, which was less than 30% canal occupancy or absence of anterior posterior epidural abscess. Of course, this is the arbitrary criteria, but this was used for understanding the disease process. We also quantified the destruction of the by the disease by the radiology, like a vertebral height loss, the deformity, canal encroachment, the cord diameter, are there any signal changes in the cord, and there is a loss of CSF space. The clinically, the parameters which we check were the symptom duration, the ambulatory status at the time of presentation, and the follow-up. So the radiological parameter were the Kopp's angle, the abscess, the canal occupancy ratio of the abscess, and the cord diameter itself. So normally we found in a wet spinal tuberculosis, the canal occupancy was considered as a more than 30% of the size, and there was a relatively thinning of the cord because of compression of the spinal cord. Whereas in a dry form, the cord, you can see there is a preserved posterior epidural CSF space, and the canal encroachment was less than 30%, and relatively the cord was preserved in its the dimensions. What we found is that the neurodeficit at the time of presentation was more or less similar, but the The pre-op AKT duration was more in a dry form. Probably they were kept on a AKT. The bladder involvement in a patients with a dry form with a neurodeficit was 50% as compared to wet form, which is almost 30% involvement. Of course, the Cobb angle was significant in a wet form because there was a significant destruction. The posterior CSS space was preserved in a dry form, which was also significant, and canal encroachment was less in a dry spinal tuberculosis as compared to the wet spine. We also saw a significant increase in the cord signal changes as well as the cord diameter in the dry form of tuberculosis. So overall, we found approximately 8.5% of dry tuberculosis in our study. 50% patients with a deficit in a dry form did not show recovery, whereas in a wet form, almost all patients showed more than one class recovery. There was a partial and complete recovery, which was much more in a wet form as compared to tuberculosis, and same was seen in a LAMS score. And 50% of the patients with a deficit in a dry form still remain non-ambulatory at the end of 12 months. And the recovery time was approximately for ambulation was around 9.5 months as compared to the wet form, which was approximately 3 months. The patients who had a complete deficit, almost 4 patients out of 7 patients still remained with a complete deficit in dry form, whereas almost all patients improved in a wet form. The bladder recovery was also suboptimal in a dry form, with a 43% showed no recovery as compared to 17% with a no recovery. Another thing which we typically see in a Mumbai with a lot of MDR and a lot of the drug defaulters, when these patients come and they improve for some time, they stop the AKT and they come back with a more destruction and instability, which causes significant deformity and deficit. Also there is something when we are differentiating this tuberculosis into dry and wet form, there's also a third type, which is a mixed variety, which behaves in a different form, which we are studying as well. Regarding the literature, Dr. Jain has mentioned about the dry form of tuberculosis in his study. And there is always a various possible reasons which have been mentioned why there is a more deficit in a dry form of tuberculosis. In the last talk, we learned from Dr. Rajshekharan that the instability is an independent factor. But here we have also seen that it could be a direct tuberculous myelitis, which could be a significant cause. The vasculitis and obliterative endarteritis can cause a significant deficit, which has nothing to do with the mechanical compression or instability. So this could be relatively benign lesion, but a severe deficit. The other theories are that there is a direct infiltration by the tuberculosis organism on the dura and the cord, and the subarachnoid blockage because of high CSF protein, which can cause a cord atrophy and demyelination over a period of time. So these are the various theories, postulated theories, why there's a significant deficit in spite of less of mechanical destruction and compression. In this study, Dr. Jain's study, he had almost only one patient with a dry form, which he labeled as a granular form. Out of 49 patients, only one patient had a dry form. And what he observed is that the patients who have a fibrous tissue, caseation, or a sequestra had a less recovery, which he called as a dry form or a granular form. And the one with the fibrous band, if you release it early, then you get a good outcome. But otherwise, he mentioned it as a poor outcome. No matter it is a dry or wet form, if your patient has a deficit or it's a progressive deficit which is progressing, or if there is any preserved neurology, we still feel that it's a factor where the decompression should be considered, and you get a good recovery, in which we have published in that. So ultimately, in conclusion, the dry form has a poor prognosis and it is associated with an incomplete recovery. There's always a high propensity of a neural deficit in spite of offering a surgical treatment or a medical treatment in the dry form. There is also a third part, which is a mixed variety where there's some caseation, some abscess formation, and it behaves differently from these two groups. And this is the variety which start on AKT and then they become defaulter, or they don't take AKT, or they have a compromised immunocompetence. And that is the variety which we observe at our centers also. And these patients, in spite of doing adequate surgical stabilization, the decompression, still these patients have a poor recovery. Of course, the limitation of our study is a sample size. Still, we had almost 18 patients with a dry form of tuberculosis. So this is something which we look forward to do a further research. But as of now, this is how the data is about the dry and wet COX in current era. Thank you.
Thank you, Tushar. You can stop sharing.
Yes.
I mean, we knew during our PG days about tuberculosis Zika, which we used to talk about in the shoulder, but something new for us to understand. I mean, we have seen those cases, but it's something new for us to understand. Thank you. We'll move on to the next speaker. Pankaj.
Yeah.
Yeah, he will be giving his talk on surgical treatment of spinal tuberculosis. What's current?
Thank you.
Good evening, everyone. I hope my slides are
Slides are
visible.
not seen.
Not seen.
Is it visible now?
Yeah, it's now
Yes.
seen.
I'm sorry, I'm traveling and my internet is limited, so I just hope I'm audible.
Yeah,
through-
sure. Fine. Please go ahead.
Having here, and I'll be delving into the surgical indications of spinal tuberculosis. I'll be not talking too much about what you already know, but what is new happening. That's what I'm going to focus on. So the learning objectives are going to be indication surgery, in presence of deficit, and when there is no deficit. Whether to go front, whether to go behind. What is the current concept of anterior column reconstruction in spinal tuberculosis? And then I'll be talking about the significance or importance of spinopelvic harmony in spinal tuberculosis. I think the previous speakers have already spoken about the goal of treatment. It's to confirm the diagnosis, achieve a bacteriological cure of the lesion, treat compression of the spinal cord, and take care of the deformity, and at least don't let the deformity progress. As I said, TB with the neurological deficit, we have been reading uh, during our entire residency. We have read Tuli, and Tuli talks about deficit, which is getting worse, which is remaining stationary, and despite fair trial of conservative and ADT alone. Paraplegia of rapid onset, spinal tube syndrome, neurological diseases, and painful paraplegia in elderly patients. These are some of the indications, neurological indications of going in and decompressing the spinal cord in spinal tuberculosis. So again, a straightforward case, a single level disease, and you can see the Frankel B paraplegia not getting better. We all know we need decompression. So this is one of the techniques we had described, and we try to preserve the lamina, and that's how it was. And we can keep the instrumentation short by doing it. Need not do a longer instrumentation. Another case, now this time it was a junctional cervicodorsal tuberculosis with Frankel A paraplegia. So it's a long segment disease, junctional area, where we did two stages, posterior and lateral surgery. And, so as I said, presence of there is not much ambiguity. We all know if there is a persistent deficit or worsening deficit or a higher grade of paraplegia to begin with, you have to go in and DS. Now, the biggest challenge comes when there is no deficit. And I think Dr. Rajshekharan already spoke about the instability. So I'll be harping a little bit on instability and other concepts as well. So here is a case where you can see this is a panvertebral disease. Or in case you get a patient who has got a bilateral facet and which is dislocating. So these are some of the indicators of mechanical instability, and these patients can present to you without deficit, mind you. He did talk about the TSIS or T spine instability score, which we gave, which will predict if this patient will land up in complications or not in case the score is higher or low. And you can see there are a few of the authors in the group who are part of the study group here. And age, location, everything was scored. Will be lost. Posterior elements, presence of multiple disease, all these was given score, and at the end we came to conclusion that if the score was less than 7, it was a stable spine, can be managed with just antitubercular treatment. Potentially unstable is a gray zone, and more than 10 is definitely unstable. It will progress either into a progressive kyphosis or heal with a progressive kyphosis, or they may land up in a neurological deficit. Again, taking you through few of the examples of of the TSIS, and this was an 8-year-old girl, and you can see there is multiple vertebral involvement and 50 degree of kyphosis. You calculate the score, it is coming to 17. This definitely is going to progress, and that's when we went ahead and did try to do a short kind of fixation and correction of the deformity as well. Another case, fairly, normal patient neurologically, a 25-year-old female, but a lot of instability pain. When you look at the CT scan, there is involvement of just 2 vertebrae, but 3 vertebrae, contiguous vertebrae involved. And again, this needed surgery, higher scores, and she did well with just instrumentation and anti-column reconstruction. Another case, this is again a young female, low backache, no deficit, And you see the entire posterior element is destroyed here. It showed multifocal involvement, but at the thoracolumbar junction, you can see there is predominant posterior column, posterior element involvement, and the spine is opening up posteriorly. Again, the score is 14. You cannot leave it alone. Instrumentation is important. Later, we validated this study and we got this published also in BJJ. All in all, I want to say, you can try this score and see for your future cases where there is no deficit. Now, the second indication of non-neurological deficit patient are the ones where you are not sure about whether the tuberculosis is drug resistant or not. This patient, so spine tuberculosis, was already on AT for pulmonary tuberculosis, and then she developed these new lesions. These are some of the cases where you have to have high index of suspicion and a low threshold of going in biopsy or going in for surgery. Atypical presentation of spinal tuberculosis. You can see D12 vertebra, which is progressively collapsing. It was a pathological kind of fracture. So again, if you come across atypical presentation of spinal tuberculosis, pathological fractures, you think about TB masqueraders and have a low threshold of biopsying or going for stabilization. Let's move ahead and now look at this 31-year-old female. She had backache for 6 months, on ATT already for 2 months. However, there's no relief of pain. Her VAS is 7 on 10. So now, how do we explain this pain? Sure, if it was an instability pain, but she had a lot of nagging pain, mechanical pain. That is the role of spinopelvic harmony, spinopelvic parameters, and we have tried to do these kind of studies, prospective studies, where we have come to a conclusion that spinopelvic parameters play a significant role in functional outcome. These patients do better if there is restoration of lumbar lordosis. You try to correct the sagittal profile of the spine by surgery, they'll have a better functional outcome when compared to conservative treatment. So in lumbar tuberculosis or thoracolumbar tuberculosis, the guidelines for surgery are very vague, and that's when I would say that there's a role of all these sagittal spinopelvic parameters coming into play. And of lately, we all know about these gap scores. This is very important to let you know if the spine is disproportionate or not, and that will guide you for intervention for better um, outcomes. So this patient had you can see she had a coronal shift also, which gradually got better with surgery. And this was a resistant tuberculosis, and that was one of the reasons why she was not responding. Yeah, and another young female, low backache for 1 year. She also had some radiculopathy on the lower limb. It was a MTB tuberculosis detected, which was sensitive to rifampicin. And she was again already on ATT for 6 weeks. We should have expected her to get better with ATT. Now that's when what I would just want to stress upon is the sagittal profile of the lumbar spine. You get it's pretty kyphotic, and you look at the gap score, it is severely disproportionate. She's going off coronally, as well as the sagittal profile of the lumbar spine is not good. That's what I feel, that lumbar spine, thoracic spine hyperkyphosis is still tolerable, but a kyphotic lumbar spine is not tolerated. And that's when we did a OLF in this patient, and did a posterior short segment fixation and try to restore her lordosis. What if you don't? This is one of the cases for me, and you can see he was a middle-aged guy, tuberculosis somewhere in his late adolescent, and which was not managed. He had a lot of pain, and he came to me with just pure basic axial backache. And it's because you can see the entire sagittal profile of the spine, of the lumbar spine, is gone, and the thoracic spine is going for hypokyphosis now. And that's when and now when you want to intervene, there's nothing less short of a Schwab 5 or Schwab 6 kind of osteotomy. So you adding on to the morbidity in case you're not intervening or going in early in these kind of cases. Coming on to anterior versus posterior, whether you want to go anterior posterior, we did this study long back in AIMS Delhi with Dr. Jaiswal, and as a co-PI, and that's what we realized, that both the approaches are comparable with regards to the duration of surgery, blood loss, fusion, functional outcome. However, the kyphosis correction potential of post surgeries is better, is more speed. Other thing with anti-surgery and tuberculosis, especially if it is involving the dorsal spine, is sometimes you can get pleural adhesions and entering the body might be difficult. But otherwise, you can try anterior surgery in case you have all those MIS, video assisted thoracoscopic skills with you in case, yeah. Okay, now so now look at this male 29-year-old male patient. He has got pain in upper back and region, and he has got all the constitutional symptoms. You can see there is entire lower cervical and upper dorsal spine is involved, and obviously the spine is also collapsing. You put it any instability score, the score is going to be higher. But now comes the point whether you want to reconstruct this anteriorly or not. So this is one of the latest results we have published and guide you should anterior construction. And this is, mind you, when you're going to do a short segment fixation. You want to do a short segment fixation, and in case your vertebral height loss is more than 0.5 and column height loss is more than 1.1 or adjusted kyphosis more than 15 degrees, you better do your anti-column reconstruction. So this patient, we did a posterior column and we did a long segment fixation in this patient, right from cervical to upper dorsal spine. And then we did a thoracotomy, sternal splitting approach with surgeons, and that's when we reconstructed the anti-column with the help of a expandable cage. This patient is with us for nearly 2 years now, and he's doing really good now. So he's happy, and luckily it was a sensitive tuberculosis also. So all in all, it went well. Quickly, I know there's another speaker who's going to talk about minimal invasive, but that is one option in your armamentarium, and this is an old study study, and I was part of the group back then. And recently we did a comparative studies, and obviously, needless to say that MIS is significantly better, especially for early post-op outcomes. However, long-term outcomes are similar when compared to open procedures. And MIS may be the only challenge with MIS, as we all are aware, is kyphosis correction. It could be inferior to open procedures. So in all, to conclude, treatment, but think about surgery if there is a progressive severe deficit, there is instability, there is a diagnostic dilemma, if the patient is not responding, and take care of spinopelvic harmony, especially when you're dealing with lumbar spine. And that's all. Thank you.
Thank you very much, Dr. Pankaj. Now we have somebody who is the innovator of a lot of small things, and that is Dr. Varun Agrawal. So over to you, Varun.
Thank you,
For
Bharat
your
sir,
talk
for such a
on
nice
MIS.
introduction. And I'll thank ASSI and the ASSI team for having me for this webinar. So these are the few cases. I hope everybody can see the screen. Yeah. So these are few cases we have been discussing, and we routinely see these in our practice. And like our beloved Dr. Tulli, he has given the middle path regime, and we are all starting AKT for these patients. But that regime was given in 1975. So in 50 years, as spine surgeons, are we evolving, or we are just still following the same old dictum? So I'll be talking about MIS and endoscopy for spinal tuberculosis. I am Dr. Varun Agarwal, Professor of Orthopedics at Rohilkhand Medical College, Bareilly. So tuberculosis of the spine and spondylolischitis has traditionally been treated as a medical management with prolonged immobilization in bed. Surgical intervention only being reserved for progressive deformity or neurological deficit. However, prolonged bed rest, as we all know, has its own sets of complication and has a very poor acceptability by the patient. And usually these patients turn up to us with more complications. So between conservative and radical surgery, are there other options? Can we have a surgical middle path? And this is what I will be talking about with endoscopy and MIS. So this is the case which I showed, 15-year-old female with caries at D7, D8, and she presented to us with complete paraplegia. And you can see on the MRI, there is a big paravertebral collection with cord compression. When we planned this case, we were going for something like a transpedicular decompression with fixation, or maybe some sort of an osteotomy. But this case presented to us during the COVID second wave, and we had a severe oxygen crisis. So we couldn't take this patient for a big surgery. So we did an under OARM guided 3D navigation. We did under local anesthesia, percutaneous endoscopic decompression. You can see how we are passing under image guidance. The pus was aspirated with the navigated Jamshedi, and this was done under local anesthesia. And you can see here the navigated endoscope with the tracker, and the cord was freed and pus was aspirated. So we were surprised when the patient presented to us 4 months with complete neurological recovery. She was, needless to say, on AKT. And we just then proceeded to do an MIS fixation after 4 months, and then the patient was mobilized. So this is how we realized the power of MIS after 1 year follow-up. And you can see 2 year follow-up, patient is fully recovered and well. Another case, 51-year-old male with spondylodiscitis at D10, D11, port spine with paraplegia and ball bladder involvement. And you can see on the images that he has a right-sided pleural effusion with ICD in situ. Also, he's a diabetic. He has diabetes, and such a patient is a very high-risk patient for general anesthesia. So we proceeded again to do the fixation and endoscopic decompression under local anesthesia again. And you can see here, this is how we pass the dilator. Working channel, endoscope, did a thorough debridement using the endoscope. And you can see the caseous material is being removed, and the pulsating cord at the end. And then finally, we proceeded again under local anesthesia for a percutaneous stabilization using the MIS pedicle screw system. This was all done under local anesthesia, and patient recovered quite well. Another case, 64-year-old female complaining of low back pain, and she was on anti-tubercular treatment since 11 months. And like Dr. Tushar said, she had some dry variety of tuberculosis. You can see on the images, there was instability due to some fibrous union because of prolonged AKT. And again, we proceeded to do under local anesthesia. We did a transcambin approach, then did a thorough debridement using these kind of big curettes through the working channel, and then finally put the bone graft mixed with the bone graft expander and a cage, followed by percutaneous screw fixation. So all this surgery again is done under local anesthesia as well. And you can see the final fixation. Patient is mobilized by the next day. She had debilitating back pain. There is vertebral body destruction. The spine is at risk as per the scores with the other speakers have been discussing. You can see on the CT as well. So we just, since she was neuro intact, we just again proceeded to do a percutaneous fixation. And on follow-up, you can see that with the continuation of AKT, the bone has started forming and the fusion is happening. And we didn't need to do any sort of decompression or a big anterior surgery to put in a cage or a graft. So another case, again, 37-year-old female, port spine at D5, D6. We just did an endoscopic decompression. This is the dilator, followed by the working channel. Use of the endoscope to get a caseous material all is removed through the endoscopic visualization. You can see how the bleeders are being coagulated with an high frequency RF. And then the pulsatile cord is visible at the end of the procedure. And all this surgery can be done under local anesthesia. And then percutaneous stabilization again under local anesthesia. So we can quickly mobilize such patients after this kind of a decompression and fixation. So another case, 32-year-old male with back pain and pain gradually progressing since the last 2 months. He is a known case of L3, L4 caries. So you can see here again a dry kind of tuberculosis. So again, we approach this case, transcambin, debridement using an endoscope. And since the spine was stable, just an endoscopic decompression, which releases the pressure of the pus in the sinusoids of the vertebra, which relieves the pain. And you can see the endoscopy images and the pulsatile cord at the end. And this is just the post-operative scar. Another case, 78-year-old male with the spondylodiscitis, debilitating back pain. So such kind of cases now, what we do is we can just put in, and we can just put in the guide wire through the transcambin route, and needle can be used for the aspiration of pus. This is followed by the guide wire and the dilator. And then we can do a thorough curettage with these instruments through the working channel. And then from the other side also, we put in this working channel. And as you can see in this video, we can do a thorough lavage of this. From one end, my assistant is putting in a lot of irrigation fluid, and I am just aspirating it from the other side. So a lot of curettage and debridement and irrigation can be done with the help of this kind of an MIS technique, and even under local anesthesia, and you can see the post-operative scar. So another case, clinical presentation. It is she's a 35-year-old female, spondylodiscitis again at L3, L4. So again, we use a transcambin approach here, again under local anesthesia. We infiltrate that tract with the local anesthetic, followed by inserting the Jamshedi. Then the guide wire is inserted like for the screws. So we stabilized on one side so that the pain and the stability of the spine is relatively there, followed by the transcambin approach to the involved level at L3, L4, followed by the guide wire working channel over the dilator. Then the discectomy is performed through the working channel, again irrigation and suction like I showed in the previous video. And then after the thorough debridement through the working channel, we just putting stimulant beads, which are now mixed with streptomycin, and this is packed in the L3, L4 disc space. So a lot of local antibiotic from the stimulant over a period of 1 to 2 months is leached, and this causes local increased availability of the streptomycin at the discitis site, and then followed by a percutaneous fixation on the other side as well. So these kind of strategies, we can handle a lot of complex cases with the MIS techniques and even under local anesthesia. We have published this in Journal of Spinal Surgery. So we did a study on 32 cases of tubercular spondylodiscitis, and patients were operated under local anesthesia, and endoscopic transforaminal decompression was done with percutaneous screw insertion. So these were our results. You can see these. So there is so in conclusion, the primary treatment of tuberculosis of the spine has been chemotherapy with limited indications for surgery. However, severe pain in the presence of spondylodiscitis without neurological deficit or deformity is an unclear situation, and usually people are reluctant to offer surgery, but the patient is basically miserable. So a temporary surgical fixation gives stability to prevent uneventful neurological recovery, promote early healing with faster rehabilitation, in contrast to a strict bed rest and external bracing. So thanks a lot for a patient hearing.
Thank you, Varun.
Thank you.
I think the overall session is now open for discussion. There have been few questions. I'm not sure Abhay is there because he said he has to go for a meeting. Abhay is back. Abhay, there have been certain questions for you. Number one, regarding the drug therapy, do we need to follow RNTCP guidelines?
I think the short answer is yes, but different members in the group are differently forced to follow the RNTCP guideline. But I think the takeaway from the ASSI should be yes, we should follow the RNTCP guidelines.
Okay. And what is the role of steroids?
So I would use steroids when there's early neurology, like power that's more than grade 3, which I plan to conserve with soft tissue cord compression, not a bony cord compression. I would take use steroid after taking the biopsy.
Okay. Any other questions to Dr. Abhay?
No, sir.
Yeah, Abhay, how do you handle this iris syndrome? The immune compromise, the reaction to that, so radiological worsening and patient does not have symptom. So how do you handle that? How do you explain to the patient, and how do you deal with them?
Yeah, so it's no longer a problem because we now have biopsy on all patients. So if you have biopsy and culture sensitivity, it doesn't matter if the radiology is worsening as long as the patient is generally getting better. if your biopsy is inconclusive and the patient, the radiology is worse and the patient is, uncertain, that becomes a problem. And we've even had situations where we've done a second biopsy. We've even had cases which have developed a secondary drug resistance because they've been given primary AKT of inadequate doses. So the primary sensitivity is positive. They've been given the wrong doses, and at 6 months or at 5 months, the MRI is worse because they've developed a resistance while on treatment.
Do you refer all your patients to ID specialist?
Yeah, I mean, I refer to a TB specialist who is well versed with the treatment of AKT. Every TB specialist is not, so they need to be, aware. And I think it's a good strategy to follow when you have a high number of or a high drug load of or a high caseload of TB spine, because there are very minute, small details that you're not able to handle. Jaundice or just compliance, nausea. Sometimes interpretation of your culture samples, etc. So I would think that that's a good message. You try to work in tandem with someone who does this better than you.
So, Abhay, you refer all patients of spinal tuberculosis or one with multi-drug resistance or poor response? What happens if your wife is not an expert in TB?
So in every hospital, I've identified one person who's good at treating TB, and I refer all of them, and I would send a message out to refer to all of all your spinal TBs. Though you should know your doses, you should know everything. It's better that the physician handle the medical part and you handle the structural part. Even if it's non-surgical, there's a structural treatment to be made. Whether bed rest is needed, exercise are needed, bracing is needed. I think that's the part that we are good at, and I would recommend that we don't dabble with AKT.
We do that only for one reason. Side effects of all these drugs, they are very well known, and you often fail to monitor them. And these guys are very good at monitoring them. So that's why, sir, we refer them for the ID as well and for the dosage as well. So that's a simple message to be given as well. Over to you, sir. Over to you, Ajay.
Thank you, Abhay. I think any question to Dr. Rajshekharan on his talk?
The talk was very good and it was self-explanatory.
No, sir.
Anybody?
So can I just ask a question to all the panelists, especially all those endoscopy being done for intact patients? Do we monitor these patients, Varun or Dr. Rajshekhar?
Well, say it again, Basu. I didn't catch it.
So it is a question on whether we should monitor these patients, these endoscopy patients, these percutaneous patients, which Varun has done so well. Most of them are intact patients. So do we monitor them? And
Neuromonitoring.
neuromonitoring, yes.
Neuromonitoring. So,
Yeah,
sir,
when yeah, go on, Varun.
sir, please go ahead. I'll take it in the next. Yeah.
No. I mean, I wouldn't monitor if I am doing a easy case where there is no partial neurological deficit or a high risk case or where there is a lot of movement of the spine to be done or correction to be done. But if it's a thoracic spine, if we are going to correct a partial deformity, then I would monitor. Lumbar spines, no.
So I would say if I'm doing the case under local anesthesia, the patient is already awake and is a self neuromonitor. So usually in these local anesthesia cases, we don't use neuromonitoring because putting all those electrodes in itself is a very troublesome for an awake patient. So if I feel there is an instability, I would first go on, since the patient is neuro intact, although it was unstable, and I would first put the percutaneous fixation maybe on one side, so provided a relative stability, and then proceed with the endoscopy. But for an awake patient, I have never used neuromonitoring.
Sir, I have a question to Rajshekharan, sir. Sir, regarding the instability in a lumbar spine, because lumbar spine, we don't get that deficit. But if your column is showing a signs of instability, how much importance do you give that? Because we have seen Dr. Pankaj Kanwal talk, he has emphasized on the alignment. But what we feel is that routinely we see a lot of lumbar cocks where we manage them with a conservative management. They heal with some amount of kyphosis. But adjacent discs are very healthy and they manage for the so-called loss of sagittal balance. So do you give so much importance for instability in a lumbar cocks where the neurology is not at the risk so much?
Yeah, if I find that the spine is unstable, then I would definitely give it an importance and then stabilize the spine, because you are not very sure of what will be the result after 2 years or after 5 years or after 10 years. Keith Look has published a series where he has shown that the primary fusion site does not give a problem, but the adjacent sites actually give a problem after 10 years, because these were all people who had spinal tuberculosis long ago in Hong Kong, but are now presenting after 25 years, 30 years with a lot of adjacent segment degeneration. So if you are tackling active spinal tuberculosis, that's a golden opportunity when the surgery is much easier, when you can do what you want and you can bring the spine to normal alignment rather than doing an osteotomy later. So an unstable spine, I would always go and fix it and bring it to better alignment.
Thanks.
Can I ask a question to Tushar?
Yes, sir.
Tushar, thank you for the nice study. So basically, as I understood, in dry tuberculosis, there is no compression or canal occupancy ratio is very low.
Yes.
But still the patients are having neurological deficit.
Yes.
But you have not studied the instability part of it. So if that is not the case, then why do you think these patients are getting neurological deficit?
Yeah. So
Because
the
no compression, there is no. I'm just trying to push in my theory that these patients may have instability.
Yeah. So we feel, sir, there's an independent risk factor, which is not a mechanical compression or instability, but it's a direct affection of the spinal cord tissue. We are saying that there could be a component of myelitis which gets neglected. There could be a component of granulation tissue, which itself causes a vasculitis in the spinal cord. It's very, even if you see the literature review, even our study, the Jain's study, the cord diameter is relatively preserved, but the signal changes and the structural changes in the cord doesn't which we don't see in a weight form of tuberculosis. So we feel that there's a different factors at play for causing a deficit and not the
Exactly.
mechanical compression or instability.
So that is exactly the reason I am saying that this could be instability. Because otherwise, what is there? I mean, vasculitis and all these are very hypothetical, isn't it? When we were postgraduates, many of these patients used to come with sudden onset neurological deficit. And at that time, MRI was not available, and then we didn't know. So one particular case, actually, a modified Hong Kong surgery was done. And the 6th post-operative day, he suddenly developed a neurological deficit. So the discussion was vasculitis, anterior spinal cord syndrome, and all that. But then we got a special permission then, and the CT scan was done, and we really found that the whole spine was like this.
Okay.
So many of these cases, yeah, I have seen a few cases also of sudden onset neurological deficit, and then they have a slight shift.
Sir, in my presentation also I had showed a cases where the disc is also intact, only subtle granulation, intact posterior elements, intact vertebral body column. So it is very difficult to correlate so much severe neurological deficit when your disc and end plates are relatively preserved and some amount of granulation is in the canal. So I don't feel in those cases, and you also see the recovery which we have studied. In spite of doing a decompression and stabilization, this patient group behaved completely differently as compared to the patient who had more instability, same level of deficit, but they improved significantly. So in terms of, so we found a difference in this cohort as compared to the.
So you think there are two different varieties of
I
mycobacteria?
think, yes, sir. Instability is an independent factor, and this dry form is also independent factor for deficit.
If you will allow, sir, I have a small comment to make, because in our endoscopy practice, I have been observing that sometimes we find some sort of spicules from the granulation tissue or some bony things which have, detached from the bone, which are not easily perceptible on an MRI or a CT scan. So those things are constantly irritating the anterior part, which is the motor fibers are carrying. And that may also sometimes I feel contribute to these kind of things out of proportion or to what we see on the MRI or the CT, because these are very small spicule which are, when we pick up from the endoscopic graspers, they are very hard, but they are not picked up on these imaging.
I just have one submission, Tushar, here. Maybe DTA has an answer there.
Yes, this is the next thing which we are thinking. A third pattern is a mixed variety and DTI. Yes, we're going to look at the tracks as well. Yes.
So cord physiology may be altered, though there may not be any structural
Yes.
compromise. Yeah.
Yes.
So Dr. Basu, please.
So no, I was just wondering the situation from a different angle. If there is no instability, how does deformity progresses? Even in some patients of adult spine where the growth potential is lost, there has to be some micro instability for the column to progress on its deformity. So I do think that in healed TB with deformity, there was a question of micro instability. Thank you. I think we are already.
There was a question in the chat box for Dr. Tushar. Is there a difference in flaccid paralysis among wet or dry tuberculosis?
Right.
Over to you, doctor.
Yeah, again, we saw a patient, so flaccid paralysis, we did not find in our study cohort in a wait forms. Most of the patients were at rest, but in a dry form, it didn't show recovery. So almost 4 out of 8 patients remained flaccid at that end of treatment.
There is one more question for Dr. Varun.
Yeah, so we are using intraoperative streptomycin because as it is, we have approached the disc space, and just adding some streptomycin is hardly a 5-second job. And it ensures the availability of extra antibiotic right at the site of the lesion. So we are getting some good responses. However, still not published something on this, but we are just collecting data.
My question is to Varun and Basu sir also. So the streptomycin is supposed to be more of a bacteriostatic, and that's why they have taken it out from this thing. So how is your experience with respect to wound depot, the depot, local depot of the streptomycin as an antibiotic in a tuberculosis? Do you routinely use it, both of?
I
No.
don't use local streptomycin.
Varun, it
So
is.
yeah, so actually I don't use streptomycin as a part of AKT, but that is the only suitable, form of antibiotic which is
Yes.
available for me to instill there. And it is an anti-tubercular drug because levofloxacin is a big vial of 500 ml which you can't really put locally. So because of that intention, we have started using streptomycin since it's part of the AKT regimen and it can be put up as a mixed with the stimulant or like that into the wound.
Can I ask the question to Varun?
Yes, sir, please.
Thank you. Varun, we know you are a magician with the endoscopes, but the principle of surgery remains decompression, bone grafting, and stabilization, what you do. But I didn't see anywhere you advocating bone grafting in your surgery, apart from just putting stimulant in.
Yes, sir. So actually, the thing is that because of the shortage of time, I had to rush through a lot of slides. We are taking local PSIS allograft,
Okay.
which we mix with with this and along with streptomycin and a graft expander because under local anesthesia, it is not really easy to have a lot of graft. So that graft expander along with PSIS graft under local anesthesia, which is mixed and then put in.
Thank you.
Thank you.
Can I ask Varun just the last question? Varun, what kind of sterilization technique do you use for the endoscopes?
So we are using ETO or a plasma actually.
So both you have facilities to do that?
Yes, sir. In the medical college setup, fortunately we have. So I really don't use the autoclave, and I personally don't like putting it in those liquids for a couple of minutes before the surgery. We have not. We have had a lot of spondylodiscitis and stuff like that. So we, as a rule, use either ETO or plasma. And if in case of an emergency, means we have to do quick turnover, then autoclave, which is used rarely.
Okay. I think thanks to all the speakers for a very good session. It was informative and a lot of new information coming out for us. We'll have 2 case presentations. We'll first invite Ayun to present for his case presentation. Ayun?
Yes, sir. Thank you. I'm sharing the screen.
Okay.
the screen visible, sir?
No.
Not yet.
Now it is visible.
Yes.
Yeah.
Okay. So this is a case, 3-year baby girl, body weight is 7 kgs, deformity and pain in upper back for last 3 months. She was started on ATT just on the basis of the clinical findings 3 weeks back. She was severely malnourished, tender gibbous deformity noted at the cervical dorsal region along with a little bit of torticollis. She had early myelopathy signs and brisk jerks. So X-ray and MRI was done, which showed a severe kyphotic deformity at the cervical dorsal region, along with abscess formation and involvement of a lot of vertebral bodies and cord compression. And after that, CT scan was also done, which showed facetal dislocation in both the 3D CTs and multiple vertebral bodies involvement. So the problems are a severe malnourished child with multiple body loss, facet dislocation, active TB, severe cervical dorsal deformity with high Cobb's angle and a high deformity angle ratio. So it's now for discussion for what are the options at present, whether we'll go for conservative or a halo vest or surgery now or surgery later for the anticipated deformity.
Can you
So
put the CTA, the MRI, what do you have?
see, so this is the MRI, and this is a 3-year-old girl child, and this is the CT scan.
Yes, anybody, anything from the faculty?
So what is the neurology at now? This is ambulatory.
She is ambulatory. She is ambulatory, early myelopathy signs with deformity, brisk jerks.
We usually get a halo traction in a place for this patient, and we approach from the front. We just decompress and put a graft, and we accept the residual kyphosis. That is, we have a few cases which we have done in that way. So usually the manubrium is quite lower down, so we can approach this lesion from the front side. If we do a minimal bone removal and drain that abscess, and these kids remarkably heal well with the medical management once, but with some residual kyphosis, which cervicothoracic junction, I have observed that it tolerates very well because the space is more. But I would like to take opinion of both eminent faculty, Ajay sir, Bharat sir.
Yes, sir.
Yes, sir.
Yeah. So I think of the options, Ayan, you put some options, just put that. Yeah, so conservative, I think, is not on the back because, as you can see, there is a complete, almost what we can call as a dislocation over there. So I think it's a lesion of T2 and T3.
Yes, sir, it's a lesion of this is the C7. It's D1. It's along the D1, T1, D2. Also involvement of T3, T4.
Yeah, okay.
This lesion is C7 and T1.
C7 and T1. So one more important thing in tuberculosis is like whatever you see here on T3, it looks like completely it's a eggshell form of vertebra, but these vertebra completely regenerate once you give anti-tuberculous therapy. So it would be wrong to just go in and remove all 4 vertebra, which will make the anterior column deficit quite huge and reconstruction a big problem. So here my concern is that this is a young child who is neurologically intact, but there is a very unstable spine at an unstable junction of cervicothoracic junction. My idea would be to first stabilize the spine. Halo traction, halo gravity traction may be a little bit risky on this patient because it's quite close to the base of the neck, and you can get sudden dislocation of the cord over here because the anterior column is so deficient. Yeah, hello, West is okay, but I would just go in now and do a primary surgery from behind. The whole question is how are you going to get implants to stabilize this? If you have a navigation and you can try for pedicle screws of C7 and C6, if not, you should be having sublaminar wire with tantalum wires, then that should be sufficient for the cervical spine and pedicle screws for the thoracic spine. I would bring the alignment to normal, stabilize the spine, and then put the child on anti-tuberculous therapy. And within 3 months post surgery, you can put them on a halo vest or some form of support. And at 3 or 4 months, I would just reassess the child and see how much of bone has reformed. In many of these patients, you can find that the anterior column, actually, I have good case series of this, but it will actually reform, and you might find that there is no much need to do an anterior surgery, or the anterior deficit is much, much smaller than what you see over here, and that anterior reconstruction will be smaller. So, posterior surgery, realign the spine, get a stable spine, and then anti-tuberculous therapy, support the spine with a collar or a Philadelphia collar or a halo vest, what you think is good. And then 3 months after chemotherapy, see what is the anterior column.
Thank you, sir. So what we did was we first maintained the halo vest, you said, for the nutritional improvement and chest physio, and continued with the anti-tubercular drugs. And in the first stage, posterior only deformity correction as much as possible was done with decancellation osteotomy. And the second stage, we thought that there was still some amount of anterior support was required. So after 1 month, the anterior fibula, just a strut graft was placed, and she was kept on halo vest immobilization. At 1 year follow-up, it was a reasonably fused at 1 year follow-up, and she was doing fine. But at 1.5 years, what happened was there was all the implants, especially over the cervical spine, there was huge implant prominence. So what next? We should retain the implants and wait, or we should go for the implant removal, because these were very tender and were very prominent and were sticking, and it was creating problems for the patient.
Yeah. So I think the problem was that even initially, even in the first X-ray that you showed, the
Mm.
screws at the cervical region were not holding on to the cervical spine, and it was out.
Yes,
So
sir.
that has been the main reason. So it would have been far better to use sublaminar tantalum wires over three of. See, if you are using this where you know that there is an anterior column deficiency, then the hold on the spine must be really good. So at least minimum 3 levels or 4 levels of sublaminar wires would have been a better idea.
Mm.
Right now, what you do with the posterior implant depends upon what is the status of the anterior column.
Yes, sir. So since it was painful and it was already fused, so implants were removed and there was complete fusion. And this is the 8 years follow-up of the patient after removal of implants, and she is doing fine. But one thing which we found out was, as we see, there was a complete fusion since she was a child, and just a periosteum stripping of the cervical spine and the upper dorsal spine, entire upper dorsal spine and the entire subaxial cervical spine is fused. We do not know how it will behave when now she is 11 years old, how it will behave after, because she has still a lot of growth potential left, and now she's doing all the activities. But thoracic length T1 to T12 at 11 years age is around 18.25 centimeter. We all know at 5 years the T1 to T12 length is 18 centimeter, and at the skeletal maturity it is about 28 centimeter. So the main concern is, whenever we do these type of surgeries and we expose it from behind, the fusion that happens due to periosteal stripping, whether that will result in problems in future or not, when the child grows up? That is I do not know. That is a question which I think we should debate on.
I don't think that will be a big problem for two reasons. One is we see a lot of people with congenital abnormalities. I mean, they have a short neck syndrome, many congenital abnormalities of the upper thoracic and cervicothoracic junction where they have quite a shortening of the trunk, and these people are able to pass on their normal life. It will be a concern if the anterior column has fused and the posterior column had not fused, or vice versa. But here, what fortunately has happened is the entire anterior column also has fused and the posterior column also has fused. So I think it is a blessing in disguise. She may have a little bit of growth abnormalities, but I don't think that's going to cause much concern or any need for an intervention.
Okay. Thank you, sir. So
Thank you, Ayan,
stop sharing.
for an excellent case. I think
Thank
we'll
you.
move on to the last speaker of the session, Sri Ramalingam. You were there?
Yes, sir. Hi, sir. Sure.
I'll take the opportunity to speak to Raja. Sir, is this cervicothoracic kyphosis when they get a multiple vertebral body loss? You usually tend to heal with some kyphosis. Is that kyphosis or internal gibbous is a concerning when these kids, because I've seen and following up them for a long time, they get a draping of the cord exactly on that gibbous, but they don't show so much of a kind of a. So what is your take on those kind of a cervicothoracic kyphosis?
That will be a concern if the posterior column was not fused. So fortunately here there is an extensive posterior column fusion also. So it is a 360-degree fusion has happened across the spine in the cervical thorax. So it's not going to worsen either in kyphosis or not. Of course, it needs careful watch, but I think it would have been a real concern if it was an anterior fusion with posterior column being intact. Yeah, Sri Ramalingam.
Yes, sir. Cameras. So is my
You can see the slide, but can you make it slideshow? Yeah, that's fine.
Fine, sir. Is it moving, sir?
Yeah, sure.
Yeah. So 1 minute, sir. Yeah. So this is a 32-year-old female presented with severe low back pain, unable to sit without support for the past 1 month, and weakness in bilateral lower limbs, and basically bedridden for the past 10 days. No bowel or bladder symptoms, loss of appetite, loss of weight, night cries, everything was there. No pulmonary or GI symptoms. VAS was around 8/10. Examination wise, tenderness in the lower back, severe restriction of movements, and she had a neurology of weakness of the dorsiflexors and EHL. Sensory was preserved with the preserved perianal and sensations. Bilateral ankle jerk was absent, and plantar was equivocal. She had a peculiar past history. She was diagnosed to have tuberculosis of the spine 6 months back at a government hospital, and started on AKT. But she developed severe vomiting and gastritis, and she stopped medications. And her family took her to a Siddha treatment, which she continued till 1 month back, and she again discontinued that also as there was not much improvement. This was the X-ray at the time of admission. It was a straightforward case, basically a paradiscal end plate erosions at L4, L5. Chest X-ray was okay. MRI showing a paradiscal vertebral lesions at L4-5 with a huge epidural abscess with the severe thecal sac compression and paravertebral abscess. These are the axial sections showing a posterior paraspinal muscle mass abscess as well as an epidural abscess and a psoas abscess. The CT showed a significant destruction of the intervertebral disc space and end plates. Blood parameter showed the LFT was normal with a rise in ESR, CRP, and a normal CBC and a hemoglobin of 10. Not much to discuss on the treatment, sir, as it's already late. I think the panel will accept that we need to go for a debridement, fixation, and biopsy, or anybody differs. Another. Ajay sir, shall I go ahead?
Yeah, please go ahead.
So,
I think we are over.
So the post-operative X-ray we did. I did this thing, and now all the investigations were sent, which gene expert showed MTB positive with the rifampicin resistance not detected. Then she was started on AKT. Now the thing starts. On 7th post-op day, she presented to the OPD with severe vomiting again, with a highly elevated LFT with significant hyperbilirubinemia, more than the aminotransferase elevation. The aminotransferase was only 3 times elevated. What do we do now? We should be.
Anyway, you have to get in a gastroenterologist.
Yeah.
Because once they have got a side effect or any adverse events with the chemotherapy, we have to get in involvement of a specialist.
The patient was referred to, all the patients are again seen by the pulmo people, sir. They gave us 2 options. One was to stop the AKT and completely and repeat the LFT after 5 days and introduce the medicines one by one, or to switch on to a liver-friendly ATT options like an ethambutol, levofloxacin, or injection amikacins. So, if the panel has any other, do we really go for a stopping the AKT, or we switch on to a liver-friendly ATT?
Bharat, what do you do in your practice?
I think I would walk with the ID specialist, would have really referred and taken his advice. Without them, we will not proceed and surrender to ID specialist.
Yeah.
So, Sriramlingam, you have one of the best hepatologists, Dr. LVK, with you. When we get into a problem, we refer all the cases to him. So you are in a very ideal position to treat
Yes.
his expertise.
So got an opinion from different hepatologists as well as our pulmo. They said even if we start on ethambutol, levofloxacin, 2-drug regime is not going to work, and injection amikacin cannot be continued for a long time. So they were of the opinion to stop ATT and repeat the LFT after 5 days and then introduce the medicines one by one, which was what was done, sir. After 5 days, the bilirubin levels started to come down. And so we started on ethambutol, rifampicin for 5 days. Then slowly after 7 days, we introduced niacid. And pyrazinamide is the most hepatotoxic drug and hence was not to be started again. And we started them on levofloxacin. Things looked like everything was okay. Then she, at 3 weeks follow-up, her back pain was better and she started to walk with a walker support. But there was not very significant improvement in her neurology. And at 6 weeks, she came to the emergency in a stretcher, unable to sit due to severe giddiness. And she had a nausea, although few episodes of vomiting, but nausea was severe and she again stopped medications and for two days. But the vitals were stable, no significant neurological deficits. Plantar again was equivocal. How to proceed? Should we start thinking of something else, or?
And I think
Or did I miss something in the first patient? Is that?
We need to reinvestigate now. We need to get all the reports done again.
Yes. So actually, one thing possibly I don't know where I missed it. We repeated the MRI of the spine. Previously, only MRI of the spine was done. MRI, CT, all investigations of the spine. But this time, we involved the neurologist, and he asked for a brain MRI. And brain MRI came to be as tuberculosis at multiple levels, including the frontal cortex, parietal, basal ganglia, and pons, which possibly is the reason for her giddiness and deterioration in her levels. So now the choice of medicines, everything went differently, and she went for a complete. She was put on complete bed rest for 2 months, and previously as I came to know steroids are the main drug of treatment here rather than ATT. And they gave steroids for 8 weeks with the oral tapering dose slowly for over 8 weeks. And the liver safe medications like isoniazid, which CSF equivalent of plasma in inflamed meninges. And cycloserine is another most important medicine which is given as for the CSF concentrations are good and good. So, and ethambutol and clobazamine was started for, and these were the 4 medicines which were continued for another 1 year, sir, till the recovery. So, at 18 months follow, patient was doing fine and she was walking around. The concern was the patient was taken, sir, for showing. And the scope for improvement is there any role for brain MRI with all those patients with abscesses, or is there any way we could miss this findings?
I do not think so. I mean, it's something very, very rare. Therefore, it's not necessary to do a brain MRI for all patients, but unless they have some symptoms which are not matching with your spine involvement, probably getting an MRI may be ideal.
Okay, sir.
Tushar, anything you want to suggest?
The one,
Sir, I agree. It's a clinical examination and highly suspicious.
But then there are cases where people now start doing a PET scan to before the start of AKT and use PET as to look at healing. Probably that would have picked it up.
I think Bharat and
Yes.
Esa could comment on that.
Rupinder,
Yes, sir.
I mean, you cannot make an exception as a general. And that is the common way in which the American system went, and then it actually made everything more and more complicated. So occasionally, like, in our practice, we have seen tuberculosis of the brain, but that happens once in 4 years or 5 years, along with the TB spine. So if you see 60 spinal tuberculosis or 80 spinal tuberculosis a year, and you do a PET for all these people, it will completely change the dimensions of treatment. So I don't think we should take it as a routine.
and sir, one more question, sir. Only this if the case has meningitis or an epidural abscess possibly, do we should we also give vigilant of meningitis kind of a presentation, or should we give? Is there any reason for giving medicines which are more CSF? Where it reaches the blood-brain barrier kind of things, sir, like the INH and these things. These patient was, because the LFT was elevated, one of the reasons that was told is she was only started on ethambutol and rifampicin first. And ethambutol doesn't cross the blood-brain barrier. And the rifampicin, it seems like only 10 to 20% of it crosses the blood-brain barrier.
Probably she already had a initial involvement. It could have been involved earlier.
Yes, sir. Maybe present.
It's a very rare scenario. It's very, very unlikely.
No need to make any change in our approach, no, sir. It remains all the same.
Yes,
Even if
that's
we,
what I
yeah.
feel. Basu, you want to add anything?
No, I think I don't want to add anything, but this is, as Rajshekhan said, is very rare. And a person who diagnoses rare cases diagnoses rarely. So I would go by the common thoughts and common processes rather than think about these things. But this case gives us an opportunity to think over these, to get a brain MRI. If someone comes with a CNS symptom like headache, vomiting, dizziness, we should think outside the box. We always think that they're due to ATD, they're due to side effects of antitubercular drugs, but it makes sense sufficient to get a brain MRI done to see whether something's going on upstairs or not.
Our ID specialist evaluates each and every bit of the body. He will look at everything, and many a times, they over investigate as well. So that is why, normally we surrender to ID specialist whom we refer, and many a time they advise, all the investigation necessary as suggested by Rupinder as well. So sometimes, probably we just have to follow what they say. Over to you, Ajoy.
Okay. I mean, my thanks to SR and Basu for giving us this opportunity. And I think we have started the ASSI webinars on a good note, a good session, including topics which are of current importance. I thanks all the speakers and all the participants, and I hope to see you all again.
Thank you.
Within the next 2 weeks, we have the coming one. We will be sending information. Thank you.
Thanks.
Thank you, sir.
Thank you.
Bye-bye.
Thank you very much.
Thank you. Thank you. Bye-bye.